Alright, good evening everyone, or good morning everyone. Sorry I didn't put this out in time, but here we go. We'll step right through it. We're talking about immunology and pulmonary disorders today. A quick review of the immune system. What are the two types of immune responses? First we have natural immunity, which is also termed innate immunity. And these are this component of immunity is responsible for an immediate response, right? So we have natural killer cells, we have macrophages, neutrophils, dendritic cells, mast cells, basophils, and eosinophils. And then secondly, we have specifically acquired immunity. And there's two types to this. There's the cell-mediated, which goes inside infected cells, and the responsibility falls on the T lymphocytes or T cells. And then we also have antibody-mediated response. This is humoral, and this responsibility falls on the B lymphocytes. Okay, so T lymphocytes go and attack the cells. The B lymphocytes kind of produce the antibodies, and so this is kind of more memory, so that it fights an infection if it's acquired again in the future. So the immune cells, the B cells, the easiest way to remember this is they make antibodies, B cells, that bind to antigens outside of a cell structure. Then we also have cytolytic T lymphocytes, or CD8 cells. They don't produce antibodies, but they do attack and kill target cells directly. And then the CD4 cells are kind of the helper T lymphocytes. What they do is they respond to B lymphocytes antibody production, and then from there they help attract CD8 cells after the fact. And as you're probably aware, HIV, AIDS destroy CD4 cells, and without CD4 cells you can't really mount an effective immune response. So again, innate or natural immunity contains all of these components, the NK cells, monocytes, macrophages, etc., etc. Then kind of the adaptive immunity, B cells and T cells. Again, T cells are made up of CD4 and CD8, and then the B cells produce antibodies that respond to antigens. So a little bit more about CD4 helper T cells. They promote type 4 sensitivity reactions, which are also known as delayed type hypersensitivity, or DTH. And if you look at the types of sensitivity reactions, you can Google this, but that's called the Gell-Coombs classification, and there are 4 types. So type 4 is T cell mediated, and it is delayed, so it's 12 to 48 hours. But when T cells are exposed to an antigen again, they will activate macrophages, which then mount an immune response. And if you get that, they would term that a type 4 sensitivity reaction. So macrophages, they begin in the bone marrow, they enter the blood as monocytes, and they infiltrate tissues, and then they evolve eventually into macrophages. They are kind of the principal scavengers of the body. They also help with the activation of T cells. They are the final mediators of that delayed type hypersensitivity. And they phagocytize cells that are tagged with antibodies. So when B cells tag antigens with antibodies, that kind of helps guide the macrophages to attack those foreign substances. And they also play key roles in natural immunity and also in inflammation. Dendritic cells are also known as antigen-presenting cells, or APCs. You can think about this as basically cells that hold up antigens so that the antigens are more visible to the B cells, so that the antibodies can attach to them. Then there are also mast cells and basophils. Mast cells and basophils have a primary role in immediate hypersensitivity reactions. Probably the most common or important part of the whole white blood cell lineage is the neutrophils. They are the most abundant granulocyte, and they make up about 40 to 70% of all white blood cells. And so when you draw a CBC, and you measure white blood cells, you're really measuring neutrophils. These can be further divided into segs, or also segmented neutrophils, and then bands. And bands are the immature neutrophils, and so when a person mounts an infection or mounts an immune response to an infection, you often see bandemia, and your bands will rise greater than 10%, and that kind of lets you know that the body or the immune system is really trying to mount an infectious response. And so it recruits as many bands as it can, and hopefully those bands will then mature quickly enough into segmented neutrophils so that they could fight infection. And then lastly in this slide is the eosinophils. They attack and destroy foreign particles that have been coated with antibodies of immunoglobulin E. And coincidentally enough, a lot of fungal infections tend to increase eosinophil counts, certainly because they are foreign particles, and so if you see eosinophilia, that might be a clue as to a fungal infection. So antibodies, these are some alternative names: immunoglobulins, which we do produce as drugs, and also gamma globulins. They are a family of structurally related glycoproteins, and they help mediate humoral immunity, which is that B-cell immunity. And what they do is they recognize and bind with specific antigens. Again, they're produced by the B lymphocytes. So when the B lymphocytes are presented with a specific antigen belonging to a specific foreign invader, those antibodies are produced. And they come in 5 different flavors, if you will: IgA, IgD, IgE, IgG, and IgM. So this slide I just kind of point out the more important ones, I think. IgM is the first antibody to be made when fighting an infection. So if you ever want to see if you've contracted an infection, and certainly with, let's say, hepatitis or cocci or even coronavirus, looking at an IgM spike will tell you if you've been recently infected with that infection. IgG is the most common antibody, and this is the one that's produced to protect against viruses and bacteria. This one does take time to make, and so if you have an increased level of IgG, then we know that you are either still infected or infectious, or that you've mounted kind of a long-term response to that infection. And then IgA is found in the respiratory tract and the digestive system. And then lastly, IgE is really implicated in allergic or parasitic infections. And then there was IgD, but it doesn't really play a significant health role, at least not to our knowledge. So antigens are molecules that induce specific immune responses. They may trigger production of antibodies or cytotoxic T cells, or both. And the antibodies recognize and bind to the selected portions of the antigen. And really more than one antibody can bind to an antigen. And so these are characteristic features of the immune response. There is specificity. So specific antigens presented by foreign invaders will mount an immune response. There is diversity. There are millions of different antigenic determinants and components. There is memory. So an exposure to an antigen then affects the immune system, such that re-exposure produces a faster and greater and more prolonged response. And this right here is, the entire thinking with vaccinations, right? We subject our bodies and our immune system to an antigen, a foreign invader, such that we hope that the B cells will create antibodies. And so if we are presented with that specific infection again, our immune system will not take the time to figure it out. It'll have already known how to deal with the infection and then mount the proper response. There is a time limitation, so nothing lasts forever. Certainly that's the same with our immune system, and which is also why we have booster vaccinations. You might see tetanus, diphtheria boosters. We give those every 10 years. Why? Because then our antibody and our immune response starts to waver. And so to kind of maintain proper immune defense, we'll give it a little booster to remind the immune system what we're dealing with. And then there's also selectivity for antigens of non-self origin. What does this mean? It means that hopefully our immune system is only targeting the foreign antigens and the foreign invaders, so that our immune system really only deals with those. But certainly we do have conditions called autoimmune disorders, right, like rheumatoid arthritis and lupus erythematosus. And that's a situation where the immune system doesn't really differentiate between self and non-self, and so it starts to attack our own bodies. So these are the phases of the immune response. There's the recognition phase, right? So there's an antigen, and it has to be recognized by the B cells and T cells. Then there's the activation phase, and this is basically a proliferation of all the components of the immune system. You certainly get an inflammatory response, and hopefully at the end of that, phagocytosis of the foreign invader. And then there's the effector phase, which is this elimination of anti-antigen with that phagocytosis. This slide is about major histocompatibility complex molecules, MHCs. Now, MHCs are a group of genes that code for the molecules. Oh, there's a group of genes that code for MHC molecules. And when MHC molecules become expressed they're expressed on the surface of all cells. When macrophages digest a microbe or a foreign invader, there's going to be peptide fragments of that invader, which will then be expressed on the surface of the macrophage that's tied to a major histocompatibility complex molecule. So if you think about it, it's kind of like a marker. So when you imagine a macrophage eating up a foreign invader, some of the bits and pieces of that foreign invader are then kind of held outside of outside of the cell, and once that it's done, MHCs bind to those little fragments, kind of like markers, a flare gun, if you will, and that helps to kind of provide more visibility to that foreign invader, and then the rest of the immune system components can then help destroy that foreign invader. In humans, the MHCs, because MHCs are across the board with all mammals, but in humans they're also known as human leukocyte antigen, and you might have seen this term before, HLAs. In class 1 MHC molecules, those are found in virtually all cells except erythrocytes. And again, they help initiate an immune response by presenting these molecules. Then there's class 2 MHC molecules. These are found primarily on B cells and antigen-presenting cells, specifically macrophages and dendritic cells. And then they help initiate an immune response by presenting these antigens to the helper T cells, CD4 cells. Cytokines, lymphokines, and monokines. So cytokines are any mediator molecule other than an antibody. It's released by an immune system cell. A lipokine is a cytokine released by a lymphocyte, and a monokine is a cytokine released by a mononuclear phagocyte, which is a monocyte or a macrophage. This slide discusses the production of antibodies. So there's going to be the interaction of the three types of cells. We talked about the B cells making antibodies. We've talked about CD4 cells, or also helper T cells, which stimulate the B cells. And then we have antigen-presenting cells, which are either macrophages or dendritic cells, that help activate the CD4 cells. There is a term called opsonization of bacteria. Opsons, so bacteria present antigens. These antigens are then coated with opsonins, which also enhance phagocytosis. So along with the MHCs, along with the CD4 help cells and antigen-presenting cells, we also have opsonization, which is again just coating this foreign invader with markers such that all the other components of the immune system can come and destroy it. And really all of these factors that lead to this mounted immune response is the complement cascade, and that activates inflammation, which then attracts even more phagocytes, and that helps to clear the virus or bacteria or whatever other foreign invader from the host body. In type 4 hypersensitivity, it's just that cell-mediated immunity. There are two branches. There's the delayed type hypersensitivity, right? So there's the activation of helper T cells and the activation of macrophages in this response. And then in cytolytic T lymphocytes, or CD8 cells, they recognize virally infected target cells, and then they will go and destroy that target, causing cell lysis. Okay, so to end off, one of your students asked about the difference between cell-mediated and humoral immunity. What do you tell her? Humoral immunity does not involve helper T cells in the immune response. Humoral immunity does not have a role in hypersensitivity reactions. Humoral immunity requires cytotoxic T cells that attack antigens directly, or humoral immunity uses cells produced by B lymphocytes in the immune response. Feel free to pause if you need to look up the answer. And the answer is D. Humoral immunity uses cells produced by B lymphocytes in the immune response. All right, moving on to immunizations. What I recommend is the guidelines and the schedules change pretty much every year, and it's hard to keep track. But the CDC provides what we call the Pink Book, and it's free. It's massive. But if you're into vaccines, it gives a lot of history on the production of vaccines, what a conjugate is, what all the different types of vaccinations and the production, whatever's involved with vaccines. So again, the Pink Book, here's the address to the CDC website to grab it. You can download it. So obviously why we created vaccines and immunizations to protect against infectious diseases, and it's the most effective method to create a highly immune population. And as you know, we've eradicated, or at least virtually eradicated, many diseases that used to plague human society, such as polio, measles, mumps, rubella, those kinds of things. Do vaccines carry risk? Of course, anything we inject into our body carries risks, but the risk of disease is much greater. This flu of, you've had the what they call the Spanish flu, the bubonic plague, which is caused by Yersinia pestis. Those kinds of things that have plagued civilization for ages could have been prevented had we had a vaccine developed. So some general considerations, some definitions. So a vaccine can be made up of whole or fractions of microorganisms. Typically they're bacterial. There is killed vaccines, which is totally inactivated, versus some vaccines that are live, and I'll point those out to you because those are important to remember. Those are toxoid vaccines, so instead of having really just the bacteria itself, we take the bacteria-produced toxins and we kind of numb it down to a non-toxic form, and it's still enough to mount an immune response. So we put that in a vaccine. And so really a vaccine can be any combination of these things. So there is active immunization. That's a response to an infection or the administration of a vaccine or toxoid. This helps create an immune response. And then there's passive immunity, and that's conferred by giving a patient preformed antibodies. So basically, immune globulins are those antibodies that contain a high amount of antibodies. And so if you are someone who's gotten hepatitis, for example, and you never got the vaccination series, you would need antibodies right now in order to combat hepatitis. And so they might give you an immune globulin that's high in antibody concentrations. So they do protect immediately because of the antibodies within the immune globulin, but as soon as the immune globulin kind of wears off or you've excreted it out of your system, then that's it. Antibodies go along with that. So we do make specific immunoglobulins, and like I gave the example before, hepatitis has an immunoglobulin. It's Hep B immunoglobulin. These are the brand names, HepaGam and HyperHep. And so they contain IgG, and if you remember from prior slides, IgG is kind of the long-term antibody-producing immunoglobulin. And so this immunoglobulin creates a lot of antibodies that are specific to the hepatitis B surface antigen. And again, so we can infuse this into you. That provides passive immunity. And how do we get that? Well, we get it from people who've been exposed to hepatitis B, who've created antibodies already. And we get them from their donated plasma. We spool it all up and then create that immunoglobulin. So to do this is really expensive and not cheap. So immunization records, I'm sure you'll be spending a lot of your time doing that if you provide immunizations in your offices. So the National Childhood Vaccine Act of 1986 requires a permanent record for each mandated vaccination. And so you might have seen children with those cards. These are the requirements. And of course, we want a record that we carry along with us wherever we go so that we know that the appropriate vaccinations have been had, and also so that we don't give you something that you've already had before. So there are some adverse events from immunization. Immunocompromised children are going to be, or immunocompromised patients really will be the most at risk from live vaccines because again they are somewhat live and these folks don't have an immune response really to combat live bacteria or viruses in them. So look for any congenital immunodeficiencies, HIV, leukemia, lymphoma, if they've had radiation recently, if they're on chemotherapy, or if they're on high-dose glucocorticoids. High dose is typically defined as 30 milligrams or more a day of prednisone, but certainly even more than 7.5 milligrams of steroid a day starts to affect the immune system. So here's a list of target diseases. Again, I encourage everyone to visit the CDC website. So for measles, mumps, and rubella, we've all combined that into MMR. For diphtheria, there's DTaP and TD. For tetanus alone, which causes lockjaw, again, there's DTaP and TD. For pertussis, which causes whooping cough, there's DTaP. And then for polio, you can get those from combo drugs, and actually there's a lot of combo drugs that kind of try to put all these things together in one shot. But there's also the polio vaccine. Continuing the slide, there's for Haemophilus influenza type B or Hib, we have ACT-HIB or PEDVAX-HIB. For varicella, which is chickenpox, there's Varivax, and this is live, so keep that in mind. For hepatitis B, we have Pediatrix Twinrix. Hepatitis A, there's Twinrix. For pneumococcal infections, we have Prevnar, which is PCV13, and Pneumovax, which is PPSV23. We'll go over that in a little bit. For meningococcal infections, we have Menactra and Menveo, which is a serotype group B. For influenza, which is annual, and I guess it's always a guessing game as to determining what H and N types we will be dealing with this flu season. And there's several manufacturers all making kind of the same thing, but Afluria, Fluad, Flucelvax, Fluzone, those are kind of all the intramuscular injectable vaccinations. The one that is right after the comma is FluMist, and you might have heard of this. This one is another live vaccine, so caution on that. But it is a intranasal influenza vaccination. You get 2 little spurts, 1 in each nostril. And so it's great for kids because there's no injection. We do have rotavirus, Rotarix, human papillomavirus, HPV, Gardasil, and then for RSV, or respiratory syncytial virus, we have palivizumab, or a product called Synagis. Just a couple points on specific vaccines. So with MMR, adverse reactions are pretty similar. You might get some injection site reactions. You can certainly get flu-like symptoms with any of these vaccinations. But again, a lot of the studies that have been done and meta-analyses that have been have really shown no causal link between MMR, a lot of the vaccines, and the development of autism, Crohn's disease, or any other serious long-term illnesses. You do have to be cautious in immunodeficiency. It is contraindicated in pregnancy. And the schedule, again, subject to change, so I encourage looking at the CDC website or the ACIP vaccination schedule. But currently it's 0.5 ml subcutaneously, and we do that 1 or 2 doses depending on certain situations. If you're giving a second dose, it would be at least 28 days apart. So diphtheria, tetanus toxoids, acellular pertussis, or DTaP, you'll get a full series and booster shots, or booster shots. If you have any progressive or unstable neurologic disorder, such as encephalopathy, or a condition called Guillain-Barré syndrome that you've had within 6 weeks, then you do not want to give DTaP. And this is the current schedule, a 3-shot series. In case you're wondering why it's DTaP like that, so a big D means that there's a high concentration of that within the vaccine. So because this is a capital D, capital T, there's a high concentration of diphtheria and tetanus antibodies in there. The A means that it's acellular, which is a fragments of bacteria, not really the whole thing. And the lowercase p means that there's a small concentration. So in this example here, DTaP, we have just a smattering of pertussis and really more diphtheria and tetanus. For meningitis, there's a new vaccine, or at least the newest one's MenB, which is, so if you look at Neisseria meningitidis, there's 6 serious serogroups, A, B, C, W, X, and Y. The longest standing vaccination, Menactra, only covered 4 of the serogroups, A, C, W, Y. And for the most part, those are the most disease-causing serogroups. And so if you get Menactra, you are certainly covered, especially if you're HIV positive or you do any travel to foreign countries. Menactra will cover you. If you're one of those patients who might be at higher risk of serogroup B meningococcal disease, then Bexsero is an option for you. I went and looked quickly as to who would be at high risk for serogroup B. I didn't really find anything in my short research. So it really sounds like that's kind of a specific case. And so for the general public and for your patient, most likely Menactra or Menveo will be the vaccine to go with. For pneumonia, for the longest time, PPSV23, and this is, so it's pneumococcal polysaccharide, that's what the PS means. And the V means valent, and the 23 means there's 23 different types of valencies that this Pneumovax covers. And so PPSV23 was the long-standing pneumonia vaccination. But in vaccination production, a polysaccharide does not confer long-standing immunity. And so if you looked at the dosing recommendations for Pneumovax, it would often require 1 shot now, 1 shot in 5 years, another shot maybe in several years. And so you had to continue like giving it, right? One company then decided that they could make a conjugate vaccination. That's what the PCV means. And for the most part, if you ever compare conjugation versus polysaccharide in the production of a vaccine, conjugates confer longer term immunity. And so Prevnar came out and it lasts longer, so you only need the 1 injection for the most part. But doesn't cover as wide a range of valencies as the Pneumovax. So the Pneumovax kind of protects you from all the little different types of pneumonia or pneumococcal disease. Now, the dosing schedule has gotten really confusing, so I recommend you look it up. But basically, if you're a chronic high disease, which is like diabetes, severe asthma or a bronchoconstriction, anything that would really put you at risk for getting a pneumonia as you get elderly. You would get 1 injection of Pneumovax, and then you would get 1 injection of Prevnar when you turn 65, and it has to be at least 1 year from the prior Pneumovax injection. And then after that, you would wait 5 years, so you'd be 70, and then you would get another injection of the Pneumovax. So it seems like for at least high-risk groups, it's going to be a 3-shot series. If you don't fall into the high-risk group, I think 1 or 2 injections is still kind of the recommendation. So influenza, if a patient has a true egg allergy, and I'm talking if they eat eggs and they just have anaphylaxis, one company does make a recombinant influenza vaccine, so this is not pooled from blood products or anything like that. Recombinant means it's synthesized in a lab, so henceforth RIV, recombinant influenza vaccine, and that brand name is Flublok quadrivalent, and so that's an option. Now if the patient just kind of gets hives or itchy but can eat eggs and survive, you can still give any of the other inactivated influenza vaccinations. And just a reminder again, flu misses lives, so if you are immunologically compromised, like HIV or on chemotherapy, that would not be an appropriate option for you. In terms of herpes zoster, the first vaccination that came out was Zostavax. It was really good because it actually protected the elderly against what can be a very debilitating disease, herpes zoster, or shingles as it's commonly referred to. But it was kind of a pain. It had to be refrigerated or frozen, I think, and it didn't really confer long-lasting immunity. This other company reformulated it into now what is called Shingrix. It's convenient. It's typically a 2-dose series, but you don't have to keep it cold. It can be kept at room temperature, and I think if you are 70 or older, it confers like a 90% immunization against shingles. And one of the things to keep aware is if a patient actually has the shingles episode, they still qualify for the herpes zoster. So don't think just because they've suffered it that they're not indicated to get the vaccination. I don't know if it would protect them again against another recurrent episode. I'll have to look that up, but I do remember that it does attenuate kind of the symptoms if they do have a shingles episode. And then in human papillomavirus, HPV, there is Gardasil 9. They used to make different versions, 2, 4, 6, 9, with 9 covering the most valencies or variations of HPV. And this is a 2-dose series, certainly before, and it can also be given in males, but one is before 15 years old, and then you do another shot 5 months after. Okay, that does it for the vaccinations. Now we're going on to the antihistamine class. So what is histamine? It's an endogenous compound, which means your body does produce it. It's found in specialized cells, and it plays an important role in allergic reactions and also in the regulation of gastric acid secretion. It's present in practically all tissues, and it's especially high in the skin, lungs, and the GI tract, but it does have a low content in the plasma or blood. Mast cells and basophils are responsible for its production, and when an allergic release of histamine requires prior exposure to the allergen. So an allergic reaction cannot occur during an initial allergen exposure. So basically, if you're exposed to an allergen that you've never been exposed to before, your body's not going to know whether it's friend or foe, right? So you're not going to really mount kind of an allergic response. But after you've been exposed to that allergen, be it dust or dander or grass, then your body knows, and so the next time you're exposed to it, then histamine release will cause all the allergic symptoms that you are well aware of. There are also non-allergic causes for histamine release, and these would most likely be drug adverse events. Certain drugs, radio contrast media, plasma expanders. These is like head of starch and dextran. They can act directly on mast cells to trigger histamine release. And once that happens, there is no need for a prior sensitization. That would just be a drug event. And cell injury can also cause direct release. So histamine, like we've talked about in prior lectures, is a kind of like a cell signaler, right? So it's a product that has to bind to a receptor in order to affect a response. So again, histamine is no different. Histamine will bind to, in this example, H1 receptors. And so in so doing, what happens if you agonize H1 receptors? Well, you get vasodilation, and that vasodilation, just like with blood pressure pills, can cause hypotension. It'll increase capillary permeability, which then leads to a little bit of pooling or edema. In the lungs, it can cause bronchoconstriction. In the CNS, it can cause some cognition and can disturb sleep. And it also causes itching, which is what we're probably most used to. What about H2 receptors? Well, if we agonize H2 receptors, we'll cause a secretion of gastric acid. And that's kind of the dominant role in acid release. So in terms of drugs, we'll go over this later, we've created what we call H2RAs, or H2 receptor antagonists, like Pepcid, Zantac, Tagamet. And so obviously those kinds of drugs will sit on the receptor, blocking histamine from binding to it. So what is the role of histamine in an allergic response? In a mild allergy, you get the runny nose, itching, and that's really caused by histamine acting on those H1 receptors. In a severe anaphylactic reaction, and if you look at the Gell-Coombs classification, that's a type 1 anaphylactic reaction. You get bronchoconstriction, hypotension, your throat closes up. Histamine in this example, in this case, really plays a minor role. There is some histamine release, but the leukotrienes go crazy, and really epinephrine is your only drug of choice in a severe anaphylactic reaction. Okay, so we have H1 blockers. These are the antihistamines that we're really most used to. When we say antihistamine, we're really talking about H1 receptor blockade, and that's for mild allergic reactions like seasonal allergic rhinitis. And then when we call about H2RAs, that's to again block the production of stomach acid. So for the antihistamines, or the H1 blockers, we can really divide them into two generations, the first generation and the second generation. The first generation can be highly sedating, and that's things like Benadryl, right? So diphenhydramine, promethazine, prochlorperazine, hydroxyzine. Those are all antihistamines that are of the first generation. The second generation, for the most part, is Claritin, Zyrtec, and Allegra. So loratadine, cetirizine, and fexofenadine are the most common second generation ones. So if we block histamine from affecting these receptors, then everything that we just talked about would be the opposite. There would be a reduction of flushing, a reduction of itching. An overdose can cause CNS stimulation, and you should kind of watch out for this. I had a patient once when I was a pharmacy manager, right straight out of pharmacy school, who this lady came to me frantic and was looking for more Benadryl, and she seemed really high strung. and I asked her how much she was taking, and she said she was taking 300 milligrams a day of Benadryl, and it like didn't knock her out. And certainly, if you prescribe Benadryl to young children, you can get this paradoxical effect where it actually doesn't knock them out; it makes them stimulated. So just kind of keep that in mind. So for uses, mild allergies. Again, for a severe allergy like a anaphylactic reaction, you're going to use epinephrine for that. Some of them are useful in motion sickness, so promethazine or dimenhydrinate or meclizine. Those are some of the more common agents. And if you have the runny nose and what forth, they're actually useful because especially the first generation ones have high anticholinergic property. And so if we talked about anticholinergics in general and their adverse reactions, they cause a drying effect, right? So they will obviously help with the runny nose. So sedation, way more with the first generation, less with the second generation. Especially in the elderly, first generations can cause some confusion. That's that CNS effect. So just kind of watch out for that. And this is certainly true in the elderly. With any anticholinergic, you can cause a lot of confusion in the elderly if they're on anticholinergics. The GI effect, again, because it is anticholinergic, you would expect constipation and not diarrhea. Its use, and I'm talking about Benadryl here. Benadryl use in pregnancy is okay. It does cross the placenta and also into the breast milk. And again, the general recommendation is if you really need it, use the lowest dose that is effective for you, and use it as sparingly as possible. If you're like that lady that came to me on 300 milligrams a day, she pushed the dose really, really high, but it's not a medication that is really what we consider toxic. It does have a large margin of safety, and certainly if you take enough of it, you get all these anticholinergic types of symptoms. And only really very rarely in extreme cases could these things happen. So again, caution in these folks. Use caution of antihistamines in young children because of paradoxical excitation, in older adults because of confusion and all the anticholinergic properties it provides. Second generation, very similar to the first generation, but they don't cross the blood-brain barrier very good. So again, probably a reason why they don't cause as much sedation. And they do have less anticholinergic effect. So Allegra is taken typically twice a day. You can use it for seasonal allergic rhinitis or chronic idiopathic urticaria, which is just a chronic unknown cause of itching. It is renally clear, so just kind of watch out for that, and watch out for grapefruit or any kind of fruit juices. It seems to decrease the effect of fexofenadine. Cetirizine or Zyrtec, I like to think of this as kind of a midway of generation 1.5, if you will. So it is a bit more sedating than, say, Claritin or Allegra, but not as sedating as, say, like Benadryl. There's a spin-off of Zyrtec called levocetirizine, which is Zizal. It's really just like a Me Too drug. And then loratadine, Claritin, again, seasonal allergic rhinitis. It's really well tolerated, and there is some caution in hepatic or renal impairment. But again, these drugs all have a wide safety profile, so it's not too much of a concern. And then another Me Too drug, desloratadine, is Clarinex. Okay, so those are the antihistamines. Now moving on to NSAIDs and Tylenol, or acetaminophen. So cyclooxygenase inhibitors, we use them to suppress inflammation, pain, and fever. But what can they cause? Well, they can cause gastric ulcerations, bleeding, and renal impairment. The inhibition of cyclooxygenase, or COX, is an enzyme that converts arachidonic acid into prostanoids. And prostanoids or prostaglandins and related compounds. Inhibition of COX-1, or what is deemed good COX, does reduce inflammation, but then you can get ulcerations, bleeding, and renal impairment. Inhibition of COX-2, which is deemed bad COX, or the worst, the more worse COX. So again, you get suppression of inflammation, pain, and fever, and all that good stuff. But inhibition of COX-2 seems to increase your risk for myocardial infarction and stroke, because it seems to not inhibit platelet aggregation as much as COX-1 inhibitors. And so we'll get into that a little bit more. So the kind of gold standard for all of this was aspirin. It's a non-selective inhibitor, which means it doesn't really differentiate between COX-1 and COX-2. And certainly it's as old as time. We've used it for analgesia, we've used it to reduce fever, we've used it to reduce inflammation. We found out that it inhibits platelet aggregation, and it does that in a permanent fashion. So once aspirin does its course, that platelet is kind of dead, the production of it, and so it's not going to be produced until the body can make some more, and that's typically a week. And so if you've ever seen people say, oh, you have to stop your aspirin a week prior, that's the reason why. Because as soon as aspirin does its thing, that platelet is knocked out, and it's not going to recover until your body can produce more, which takes about a week's time. Of course, we do that on purpose when we have post-stroke, post-MI, when we're trying to prevent platelet aggregation, and hence the term thinning the blood out. So we have GI effects, bleeding, obviously. What is inherent to aspirin is salicylism, and the major side effect of that is tinnitus, which is a ringing in the ears, and some headache and dizziness. It certainly can cause Rey syndrome, and Rey syndrome is an acute liver failure, and the patient population you want to really be concerned about is kids less than 18 years old, who have a concomitant viral infection or have had a viral infection in recent weeks. If you give them aspirin, there is a possibility that they can develop Rey syndrome and an acute liver failure. So for the most part, avoid aspirin in kids. And sometimes they do use it in pregnancy on purpose, but obviously because of these effects, it can cause anemia and hemorrhage. Drug interactions, again, just think it's an antiplatelet, so anything that increases risk of bleeding, or risk of ulcerations, risk of any of that stuff is going to be an interaction. So anticoagulants, glucocorticoids, because they can cause gastric ulcers. Alcohol can thin your blood. Ibuprofen is going to work similarly. ACE inhibitors and ARBs with renal function. If you have an acute poisoning, you'll have a metabolic acidosis. The patient will become dehydrated, and treatment will be largely supportive fluids and treating the acidosis. First generation NSAIDs, they're similar to aspirin, right? But they have fewer of the adverse events. Well, and I should point out, for all intents and purposes, aspirin, or what they call baby aspirin, 81 milligram aspirin, is really the minimum amount of aspirin we need to cause platelet inhibition. And so certainly most patients will be on a baby aspirin to do that. Now, you can Google the number of NSAIDs there are. There's a bajillion. They're all Me Too's. Some have certain advantages over another, but for the most part, ibuprofen is kind of the de facto standard. So they are also non-selective. They'll inhibit COX-1 and COX-2. Some inhibit one more than the others. The first generation NSAIDs, ibuprofen, naproxen, ketoprofen, oh gosh, there's so many, meloxicam, nabimetone, oxaprozin. Anyway, all those tend to inhibit COX-1 more than they do COX-2. And we use them really just for osteoarthritis, pain, joint aches, and fevers. So here's ibuprofen. Brand names are Advil, Motrin. Again, kind of all the same stuff. I do like to throw in naproxen as another over-the-counter available medication, which goes by the brand name of Aleve. Very similar to ibuprofen, but it tends to last a little bit longer, so you take it less times during the day. And then there's the second generation of NSAIDs. Again, very similar to the first generation, but these ones tend to hit COX-2 more, and because of that, these agents have been implicated in a higher risk of MI and stroke. And in some of them, they've actually been pulled off the market because of that. So really, the only COX-2 inhibitor that is available on the market now is celecoxib, which is Celebrex. And I think this was the first one. And so certainly it's still available. And if you have patients who are at higher risk for kind of the gastric bleeds and what forth, but at low risk for strokes and MIs, Celebrex might be a possibility. There were two other agents that used to be on the market, but again, like I said, a lot of those patients had MIs and strokes, and so they pulled them off. And you may have seen them. One was Bextra, and the other one was Vioxx, valdecoxib. Acetaminophen, again, just like aspirin, as old as time. Pain, inflammation. You might see Tylenol PM being marketed. A lot of elderly folks are on that, which contains Tylenol and Benadryl, which is not really a great choice. But it's safe in children, especially in neonates and pediatric patients. Doesn't cause this Reye syndrome. So, if you give Tylenol prior to receiving a vaccine, there is a possibility it might reduce the body's immune response to that. So we tend not to recommend that. So adverse events at very few normal doses. It is pretty safe. As you are probably aware, it does go through the liver. But if you stick to the normal doses, you're really not going to get into any troubles unless you have pre-existing liver condition. Very, very rarely, it can cause some wild skin disorders like Stevens-Johnson syndrome or AGEP or toxic epidermal necrolysis. Again, very rare. Hepatotoxicity, and arbitrarily, or at least what the study shows, that if you go over 4,000 milligrams a day or 4 grams a day, your incidence of hepatotoxicity will increase. And so patients who are suicidal, you would probably not want to give them a whole bottle of acetaminophen, because that's one of the more common ways to overdose on something in case you have suicidal ideation. But it's certainly taking a whole bottle of acetaminophen, which is greater than 4,000 milligrams, way over 4,000 milligrams, will cause hepatic necrosis, and that will cause your liver to die. And the treatment or overdose for that is acetylcysteine or mucomist. So a patient who's taking aspirin for rheumatoid arthritis is admitted to the hospital complaining of a headache and has ringing in the ears. They draw a plasma salicylate level, and they find it to be 300 milligrams per liter, and the patient's urine pH is slightly acidic at 6.0. What will you do? Do you increase the aspirin dose so that they treat the headache? Prepare to treat for possible renal toxicity? Prepare to provide respiratory support because the patient shows signs of an overdose? Or hold the aspirin until the patient's symptoms have subsided? You can pause if you need to. The answer is just to hold aspirin. This is a sign of tinnitus and of salicylate toxicity. But yeah, that should resolve on its own. Okay, now moving on to glucocorticoids, also known as corticosteroids. So these are nearly identical to anabolic steroids. or I mean, sorry, steroids produced by the adrenal cortex, cortisone being that endogenous compound. At low doses, they modulate glucose metabolism, and at high doses, they can suppress inflammation. So the metabolic effects you certainly have to be very cognizant about if you're going to put any of your patients on long-term steroid therapy. It can cause diabetes, and in many cases, depending on the dosage, quite wildly. They do, very long-term anyway, it can cause a reduction in muscle mass. They can cause osteoporosis, again, long-term. Skin striations and thinning, long-term. Lipolysis, long-term. And then you get this redistribution of fat. Patients will have a pot belly or a moon face or a buffalo hump. And pretty much all of these are kind of more long-term, except for the blood glucose thing that tends to, you do tend to see that effect quite rapidly. So in low levels of endogenous glucocorticoids, this is like if you have adrenal insufficiency, right? So your body is not producing the amount of cortisol that's needed, that is normal. That can cause quite a amount of vasodilation and can cause a hypotension. It can drop your sodium. And so these are things that you see in a typical adrenal insufficient patient. And so glucocorticoids help increase certain red blood cells, especially white blood cells. So if you ever draw a CBC and you see that the white blood cell count is elevated, past normal, but the patient doesn't look infectious, they're not feverish, they don't show a bandemia. One of the things I ask on rounds is that patient on a steroid, because that can cause that. So why do we need steroids? Well, it's part of our stress response, right? So the adrenal cortex releasing cortisol is a proper response of our bodies in times of stress. And so certainly if we're having a stressful moment or we're fight or flight, trying to run away from some kind of danger, the steroids help to maintain a high blood pressure. And also maintain blood glucose levels and flood the blood with sugar, because sugar is fuel. And so if your body is trying to run away from something, your muscles are going to burn energy, and the body is going to want to feed the muscles with some energy. And so the corticosteroids kind of help prime that. And so obviously if you don't have steroid, right, if you're adrenal insufficient, that can cause death. And hopefully you're putting these things all together, right? So steroids can help mimic the effect of aldosterone, or can at least call upon that RAS system to promote the retention of sodium, and where sodium goes, water follows. And this is all to kind of increase your blood pressure, so that you get hypernatremia and hypokalemia. And certainly there are conditions. So the opposite of adrenal insufficiency would be Cushing's syndrome. And in Cushing's syndrome, you're producing too much cortisol, too much steroid. So what do you see with those patients? You see them being with hypertension. You see them with hypernatremia. You see them with hypokalemia. You see them with diabetes, because again they're producing too much. So most glucocorticoids as drugs have very low mineralocorticoid activity, and really mineralocorticoid activity is what drives this aldosterone response. Except for fludrocortisone, it's really the only steroid that we use that has a high amount of mineralocorticoid activity, and we will use this in cases of orthostatic hypotension, or in hepatorenal syndrome, where we need to retain more sodium because of low blood pressure. Fludrocortisone is a drug that can do that. In neonates, the adrenal glands will release a burst of glucocorticoids that helps with breathing in a full-term infant, and steroids as part of a stress response help to cause lung maturation. And so what we would worry about is if you are a premature infant, you might not get this kind of response, and so you could have immature lung development. And so studies have shown that if you're a preemie, to prevent the incidence of respiratory distress, we will give betamethasone at least 24 hours before birth, and then another dose right after. So unlike a lot of the other types of drugs which we produce some kind of cell signaling compound like histamine or dopamine or serotonin or catecholamines like epinephrine, norepinephrine. All those things are like compounds that then have to go and find a receptor that have to sit on that receptor in order to create an effect. Well, in this slide, steroids are a compound themselves that actually go inside into the cells. And what they do is they modulate the production of regulatory proteins rather than signaling pathways. And so whereas in the prior example, receptors are usually outside, you affect that receptor, then some kind of effect occurs. Steroids happen to enter cells, and that's where they have their effect. So adverse events of steroids, you can get adrenal insufficiency with prolonged exogenous administration, and I'll kind of cover that a little bit more on the next slide. Like we said, long term you get fat redistribution, muscle thinning, osteoporosis. You can increase your risk, because it's an immunosuppressant long term, you can increase your risk for diseases that kind of mimic what we see with HIV patients. You can be at higher risk for PJP. You can get diabetes, and then this myopathy. So that negative feedback, here's kind of what's going on in your brain. You have a hypothalamus, which then releases corticotropin releasing hormone, which then signals the anterior pituitary to go ahead and secrete adrenocorticotropic hormone. That ACTH then enters into your adrenal cortex, on top of their kidneys, then signaling the adrenal cortex to go ahead and release cortisol. Well, cortisol has a negative feedback mechanism, such that when there's enough cortisol being produced, it then comes back to the hypothalamus and it stops this activity from happening, right? And so once you have enough and you've got enough appropriate stress response, that negatively feedbacks into the hypothalamus, and the tells the hypothalamus, okay, you can stop now, you don't need to release this stuff. And all of this is what we term the HPA axis, the hypothalamus pituitary adrenal cortex axis. So if you can imagine, if we're giving you oral steroids that are really taking the place of this cortisol, those oral steroids will have the same negative feedback mechanism on the hypothalamus anterior pituitary, which then shuts off your internal production of cortisol. Now, if I were to stop the steroid cold turkey and this was all suppressed, there would be a period of time where you would not be producing any cortisol, and that could put you in danger because you would have no appropriate stress response. And that is the reason why with steroids it's important, especially if you've been on it long term. And long term being probably 2 weeks is when this whole thing starts to kind of get shut off. So if you've been on the steroid for at least 2 weeks, tell your patient they need to taper down such that we slowly introduce cortisol production back into the game, and we don't induce some kind of adrenal crisis. This is just a recommendation. There is really no gold guideline for tapering a dose. You can start with 7 days. If the general rule is if a patient's been on a steroid longer, say months, then you should also try to reduce it kind of in the same amount, such that it takes longer, to slower going, so you don't induce an issue. Yeah, and then you just monitor for signs of insufficiency. So if you're tapering someone down and they start to have some kind of side effects from it, bring them back to the last dose that they were comfortable with, and then just kind of go slower in your tapering. And then again, same things with all the side effects with having steroids in your system. What we didn't talk about is the effect on the eyes. So long-term therapy can increase your risk for cataracts and glaucoma, and also with peptic ulcer disease. So if you're going to be on a steroid, it's probably a good idea to put someone on a PPI like Protonix. Iatrogenic, meaning we caused this, right? So iatrogenic Cushing syndrome, we're causing it because we're giving the patient steroids. So that's what you get with steroids. Just think of the interactions, NSAIDs because of stomach ulcers, insulin and hypoglycemics because of the play and effect on blood glucose, interactions related to potassium loss, and then vaccines because it blunts the immune response. We try to avoid, again, because of the immune response or blunted or inhibited immune response from high-dose corticosteroids, you wouldn't want to have someone with a concomitant fungal or bacterial or viral infection. They do come in various routes, most commonly being oral, but we do have parenteral ones, and some patients who've had bum knees or whatever can get steroid shots. And if you're going to compare glucocorticoids, they kind of differ in three ways. Ones that are biologic half-life. For the most part, most steroids last quite a bit of time. Hydrocortisone is probably the least lasting steroid. We talked about mineralocorticoid potency. For the most part, none of them really have a significant mineralocorticoid potent effect, except that fludrocortisone one. But there is some. And then you can compare them by their glucocorticoid potency. So I didn't write it down here, but hydrocortisone, you can write this down. Hydrocortisone 20 milligrams is roughly equivalent to prednisone 5 milligrams, which is then roughly equivalent to 0.75 milligrams of dexamethasone. And certainly there's more and more and more, but those are the most common ones I see, so you should stick to those. Steroid dosages are highly individualized, which really means just based off the disease state you're treating, kind of go with the guidelines there. So for less threatening diseases, you can go low and slow. So my general rule is 2.5 to 5 milligrams of prednisone. It's kind of a low dose, and you can start with that. If it's an immediate threat, let's say like a septic shock or adrenal crisis where a patient doesn't have any steroid in them, we'll do 100 milligrams of hydrocortisone IV or methylprednisolone IV, but basically it's going to be an IV route for that. So again, go low, go slow. Same thing as the same principle applies if you're trying to wean a person off, and try to administer it right before breakfast, or at least with breakfast. It can cause a euphoria, and so you don't want to give these close to bedtime. And they also can increase a person's hunger. So I always joke when I consult patients, don't take it while you're going to a buffet. All right. So a patient's about to receive prednisone for the tendinitis, and after reviewing his present illness, you are most concerned about asthma and allergic rhinitis, candidemia, gouty arthritis, or seborrheic dermatitis. The answer here is fungal infections. All right, Now going over asthma and COPD drugs. As you're probably aware, asthma is a chronic inflammatory disorder of the airways that is often reversible with or without treatment. There is a degree of bronchial hyperresponsiveness in asthma. Contrast that with COPD, which is a chronic, progressive, largely irreversible disorder characterized by airflow restriction and inflammation. There's two types really. Chronic bronchitis is a persistent cough plus positive sputum production for most days of the week out of 3 months. And then there's emphysema, which is an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of alveolar walls. Here's kind of a diagnosis chart. So asthma typically presents in the younger, COPD older, probably with the biggest driving factor being smoking, and certainly secondhand smoke, or if you're in any kind of industry that you inhale toxins that can cause COPD. So there's variation in asthma, and it's usually triggered by things. In COPD, it's kind of a waxing and waning. You can do lung flow test, right? Pulmonary function test. And certainly with asthma, it is reversible, or at least you have a better result in your peak expiratory flow if you give a bronchodilator, whereas in COPD, bronchodilators really not tend to change that result as much. In a chest radiograph, chest x-ray, asthma patients present as normal-looking lungs. And in COPD, you'll see severe hyperinflation with the use of their accessory muscles and the chest barreling. And in most recent years, there's a kind of a what they call asthma COPD overlap, or ACO, where you really can have kind of features of both components. And so if you have 3 or more boxes checked for either category, then you might be dealing with a mixed type of asthma COPD overlap. So we're going to go over the drugs. There are the anti-inflammatory agents, the steroids, and then the bronchodilators. Why do we inhale the drugs? Obviously because we want delivery to the lungs for the most enhanced and most effective action as possible. And so there's different types of inhalers. These are the ones that you're most used to seeing, the meter dose inhalers. These are the ones that patients kind of shake around. They contain a propellant, and the propellant helps to kind of push the drug into a nebulized form so that the patient can inhale it. There's these new formats that drug companies have made called Respimats. They're kind of like, I like to think of them as bongs when you're like doing drugs. They create a mist, kind of like a portable nebulizer. And then you just kind of inhale it from there. There's dry powder inhalers, and these ones, it's basically a capsule that they poke a hole into, releasing the powder, and there's no nebulization to it, so it's just dry powder, and it requires the patient to have a really strong inhalation. They have to suck it in as hard and fast as possible in order to suck in that powder. And then there's the traditional nebulizers. You take a liquid, you put it in the machine then creates a mist out of it, and then you put a breathing apparatus into your face, and then you sit there and you kind of breathe in the vapors for an extended period of time, several minutes. So for asthma, which has a high degree of inflammation, you're going to do kind of glucocorticoids, which is referred to as ICS, or inhaled corticosteroids, and there's several in the market. We'll review those. I'm not going to go over that too much. Again, we've kind of talked about glucocorticoids, and really in asthma patients, this is kind of the long-term treatment, right? So if you're going to treat asthma, we're very used to seeing albuterol being used for asthma, but really that's a short-term treatment. You should really put them on an inhaled corticosteroid, and that's going to be something that they're going to do long-term, whether they have symptoms or not, because that helps to reduce and keep the inflammation down, which then doesn't cause this hyper response to certain factors that can trigger an asthma an asthma attack. They do steroids orally, and this is really just severe cases of asthma. If it's an asthma attack that causes you to come to the ER, they might do, usually it's 40 milligrams of prednisone, no more, and they'll typically do that for like 5 days. Now, with inhaled corticosteroids, right, so if you're going to give a patient an inhaled corticosteroid, a couple of things to remind patients. You can look up the dosing depending on your patient, but again, it's going to be not on an as-needed basis. This is going to be a scheduled medication to help reduce inflammation, and then to also help, hopefully, reduce the number of exacerbations that they have, and also have them rely less on their albuterol. And then, because it's a steroid that you're putting into your mouth and inhaling, you do have to watch out for candidiasis, so you have to remind them to rinse out their mouth after each puff. And the steroids, especially in the beginning, can cause dysphonia. It can cause a kind of a deepening or hoarsening of the voice, which is not something to be really concerned about, just more cosmetic. All right, moving on to leukotriene modifiers. So leukotrienes, as we learned in the previous slides of the immune system, they do have an effect on the inflammatory cascade. They promote smooth muscle constriction and blood vessel permeability, and also mount an inflammatory response. So what if we had drugs that inhibit all this? Well, we do. And so leukotriene modifiers basically block the effect of leukotriene, so that reduces bronchoconstriction and also reduces the inflammation that can be brought into the lung spaces. They are second-line agents because they're all oral, and they're generally well tolerated. There was several years back, there was a push by civil groups to put Singulair onto the over-the-counter market, and it was being reviewed by the FDA. But because of this rare effect, but it has been known to happen, it can cause a neuropsychiatric effect such as suicidal ideation or depression. They decided not to, so that's why you don't see them. Otherwise, they're pretty safe medications. Xylutine or Zyflo is probably the least seen. You have to take it like 4 times a day, which is a pain in the butt. This is the only one that actually inhibits the formation of leukotriene, and that's kind of its thing. Headache is a big thing. That neuropsychiatric event that we talked about, rare cases of hepatotoxicity. Now the other agents, they don't actually inhibit the formation, they just block the receptor. So accolate, zafirlukast, and montelukast, Singulair, they sit on the receptors and block them. Again, headache. This weird side effect, which I've seen before happen, it can cause what was formerly known as Churg-Strauss syndrome, but now is known as eosinophilic granulomatosis with polyangiitis. It's a eosinophilia, so eosinophils go up in count, and it can cause this vasculitis, so all the vessels in the body become inflamed from this. Also, again, like the Zyflo-Xylutine, it can cause rare cases of hepatotoxicity. There seems to be an increased risk of infections if you're greater than 55 years old, and again, depression and suicidal ideation. Here's Churg-Strauss syndrome. So here's a guy who's, obviously you can't see inside with his vessels, but if you can imagine, the vessels are all just inflamed, full of eosinophils, and that causes sinus problems, asthma, muscle joint aches, pins and needles nerve damage, which then kind of you can see here on the skin. We've talked about cromolyn before, a very safe drug, but very weak, with a very slow onset. This is a mast cell stabilizer, so it inhibits mast cells. Certainly you can recommend it. I typically don't, just because it takes very long and it's not as potent as other medications, but it is very safe. There is an agent called omalizumab or Xolair. This is an injection of IgE. It blocks IgE. And this is really just if a patient's been on every asthma medication known to man, nothing is happening, nothing is helping, they're still symptomatic. This is kind of the last line agent, and it's a sub-Q injection. Here's kind of a list of side effects. Okay, so we talked about inhaled corticosteroids, we talked about leukotriene modifiers, we talked about mast cell stabilizers such as cromolyn, and then an IgE antagonist or inhibitor in Xolair. Now we're going to talk about the beta-2 agonists, and if we remember correctly, beta-2 receptors sit primarily on the lungs, and agonism or activity on the beta-2 receptor will cause bronchodilation. So obviously with the constriction of the airway spaces in asthma and COPD, bronchodilators help to open those up, right? So there's short-acting ones, which we refer to as SABAs, or short-acting beta agonists. This is albuterol, right? So you took those usually as needed to abort an ongoing attack. If you have exercise-induced bronchoconstriction, you can take it before exercise, typically 5 to 15 minutes prior to exercise. You take a puff, and then that tends to last a couple hours so that you can do your exercise and not have bronchoconstriction. Certainly if you're having an asthma attack, as soon as you get to the ER, they'll nebulize you, and then they'll just stick a mask on you, and then you're going to breathe in albuterol. There are also long-acting beta agonists. Salmeterol, formoterol are those kinds of agents. They last longer, typically 10 to 12 hours is their duration of action. They don't take effect as quickly as short-acting beta agonists, so we typically don't use them to abate an attack. One of them is indicated for exercise-induced bronchoconstriction, but you have to use it 15 minutes prior to exercise. Now there was a weird study a couple decades ago called the SMART trial. They looked at asthmatic patients who just used LABAs alone and found out that those who used LABAs alone had an increased risk of serious adverse events and asthma-related deaths. So if you're treating asthma, we don't recommend these agents alone. Now in COPD, yes, we do recommend these agents to help with their breathing, but in a pure asthma patient, not this agent by itself. Beta agonists, again, with anything, if you spill over, right? If you give too much of a drug, no drug is 100% specific to a receptor, right? So what is the other receptor that we can affect if we spill over? Beta 1, and so beta 1 receptors sit on the heart, and so if you use too much of the beta 2 albuterol, it can spill over and start to affect beta 1 receptors, and what does that do? You can cause tachycardia and angina and tremor. Okay. Other bronchodilators include this. It's kind of like a third line agent, but the methylxanthines are old, and the theophylline was kind of the first agent. There's also a product called aminophylline, which is an IV that's used in kids. Again, you don't see these very often anymore. Not only do they have a weak effect, they're very narrow therapeutic drugs, so you can quickly get poisoned by these medications if you're not careful. But they do inhibit phosphodiesterase 3, and to some degree phosphodiesterase 4, which increases cyclic AMP, which then causes more muscle relaxation of the bronchioles. And the golden rule is to keep that theophylline level between 10 and 20 milligrams a liter. And certainly if you go over this, it can get toxic and dangerous. We've seen low doses of theophylline used, doses that don't even hit this plasma level, but I've seen it in like cases of COPD as a steroid-sparing agent. So patients who are on theophylline and some other agents, they seem to have a sustained effect with these agents on board and still reduce their amount of steroid usage, and that's always a good thing. Steroid sparing. So here's what we need to look at. So if we go past 20 milligrams a liter, we start to get nausea, vomiting, diarrhea, and this is what we really want to caution our patients. So if you're going to prescribe theophylline, or if you do a drug review, look for theophylline and ask the patient if they've ever been feeling nauseous, have they ever vomited, or have they ever had diarrhea. Because then I would want to pull a theophylline level to ensure that it's well within range. If it gets above that, then you start to have some kind of arrhythmias, including ventricular fibrillation, and then you can have death. If you have a patient who has toxic theophylline, obviously we're going to stop it. You can do activated charcoal to absorb the theophylline that's in the gut, assuming that they haven't absorbed it already. If you have ventricular fibrillations, the 1B agents, and we talked about the 1B agents, the 1Bs are, remember, sodium, and the B is the weaker part. So weak sodium blockade agents like lidocaine, mexiletine, toconide, those are the agents we use for VFib. If the patient seizes, then you'll give a benzo. Here are some of the drug interactions. Caffeine can inhibit the metabolism of theophylline, so just kind of watch out for that. And then here are anticholinergic agents. So the first of this is ipratropium, and now they've made several more. Ipratropium was the first one, but it's short acting, right? So they've made several since ipratropium that are longer acting, but these block muscarinic receptors, thereby reducing bronchoconstriction. This has more of a play in COPD than it does with asthma. Okay. So again, we're going to give it. It kicks in about 30 minutes. It persists roughly about 4 to 6 hours. So if you're on ipratropium, you'll be seeing patients take these about 4 times a day. Because muscarinic is cholinergic, and we're blocking that. By definition, this drug is anticholinergic, right? And so you can expect dry mouth, glaucoma, things of that nature. So tiotropium is the longer version of ipratropium, right? Tropium. So tiotropium is once a day. It's long acting. It is actually a pretty good drug. It's not approved for asthma. This is for COPD. But if you look at tiotropium, again, anticholinergic, it came out as Spiriva as a dry powder inhaler. So it works really well. And some studies have even shown it improved their quality of life and reduced exacerbation hospitalizations. So as far as a long-acting anti-muscarinic agent, I like tiotropium. The dry powder inhaler, again, you have to assess your patient's ability to do a forceful inhalation. If they have a hard time inhaling forcefully, they probably will not suck enough of the powder. So it has to be sustained, and it also has to be forceful. And you can kind of Google those things or YouTube them to see. Some of these agents require like a forceful sustained inhalation of several seconds, which can be pretty difficult for some folks. Aclidinium is one of the newer anti-muscarinic, anticholinergic agents. So similar to tiotropium, aclidinium. And here's kind of a list. So tiotropium was kind of the first long-acting one, Spiriva. Aclidinium goes by Tudorza. Umaclidinium is called Incruse ellipta. And then this newest one is revefenacin or Upelri. Of course, drug manufacturers like to make money off of us all, so they go ahead and combo these things. So you take those long-acting beta agonists, you stick them with a steroid. This combination is okay in asthma patients, all right, because it's not just the LABA itself, it's tied with a steroid, and so that's okay. Advair is probably the most common one. It's fluticasone salmeterol. It comes as a dry powder inhaler. They have also made since then an MDI meter dose inhaler, so it comes in both flavors. Symbicort and Dulera are another agents. How do you decide between any of these three? You don't. You just see what the insurance covers, and you go with that. From there, you're just going to figure out what dose, right? This is a classification of asthma that I've thrown on here. So we go by symptoms, right? So there's going to be either 4 categories. You're going to be either intermittent symptoms, mildly persistent, moderately persistent, or severe persistent. And you can see, frequency of symptoms, the number of times they have to wake at night, the number of times they use an albuterol inhaler, right? So if it's someone that uses it daily, right, they would fall into the moderately persistent category. If you do a pulmonary function test, FEV1 is the forced expiratory volume over 1 second. That's like saying blow into this pipe as fast and as much as you can over 1 second. And so in patients who are doing worse, there's going to be a reduction in that. And then they also measure FEV1 over the percentage of normal. So in a normal person, most of their forced vital capacity, which is how much breath you can get out of your lungs, most of that should be delivered over the first second, right? And that's that forced expiratory volume. So if you were to exhale all your breath as much as possible, most of that should come over the first second, and greater than 80% of that should be the case. And in asthmatics, that's not the case because they have a hard time exhaling that stuff out. So this is useful to kind of study because after you figure out where the patient lies on this chart, say they're moderately persistent, then it kind of tells you where you should initiate treatment, right? If this is a person you're seeing that's asthmatic for the first time in your clinic, you'll say, okay, this person who's an adult is moderately persistent. I'm going to go with step 3. This is assessing asthma control in adults and children. So this is a patient who is already on treatment, not your first go-around, who you've given treatment, and based on these kind of points, and the ACT is a questionnaire. Based on these categories, you can kind of determine, okay, is the treatment working? Do I need to step up? What do I need to do? So this kind of helps guide that. So this is kind of the drug treatment chart. So going back to the prior example, step 3 here, I would start here at step 3. In an adult, I would add a low-dose inhaled corticosteroid plus a long-acting beta agonist, or just give them a medium-dose inhaled corticosteroid. And then also everyone gets the albuterol, right? 2 times, short-acting beta agonist albuterol. So kind of study this chart, kind of helps you guide your treatment. Obviously, the worse step you are, the higher the treatments will be. So like in this example, high-dose inhaled corticosteroid plus a long-acting beta agonist plus systemic corticosteroids, like a short course of prednisone, and tiotropium, and omalizumab, such and such and such. So, along with drug therapy, it's also important to go over with the patient their exposure to their environment. So I like to ask patients, what is their home like? Do they have pets? Do they have, a lot of dust? Do they have carpet? Is there anything that could trigger these events? Oftentimes patients don't know about the existence of mold, so I would go and look for, is there any black mold growing that you didn't expect? Those kinds of things. So look for those: house dust, mites, pets, cockroaches, molds, tobacco, any of these triggers, especially for patients who often seem to have exacerbations. And then this is if you're, kind of the ER nurse practitioner, but obviously if you've got an asthma attack, it's going to be, in albuterol, oxygen, systemic glucocorticoids, oral prednisone, to kind of get their breathing down. Some tips for exercise-induced asthma. Again, you can use a short-acting beta agonist kind of right before exercising, or a long-acting beta agonist. I believe Ceravent or salmeterol has an FDA indication for exercise-induced bronchospasm. So that one I think is done 15 minutes prior to exercise. So yeah, and I would stray away from cromolyn. I don't think it's very effective. So, okay, some more stuff about the, reducing exposure to environmental triggers. So just kind of keep these in mind. These are some of the agents, kind of broken down in a class. So these are the inhaled corticosteroids. Is there a difference between any of these? No, there's really not. Again, decision making is driven by insurance coverage. Once you know what drug is covered by the insurance company, then you can determine what dose is appropriate for your patient. Again, some of the tips: oral candidiasis, so remind your patient to wash their mouth out. And really the most important thing, and you might not have the opportunity to do this with the patient in your clinic, but certainly have them talk to the pharmacist, because if it's the first time they've ever dealt with a meter dose inhaler or a dry powder inhaler or a Respimat or any of these funky devices, they really need to be shown, and they also need to be able to teach back what they're doing. So if you've started a patient on a medication, make sure that they bring it to you, bring it with them to show you, and ask them to show you how they're taking it. And you need to be able to assess how they're doing it to determine whether it's effective or not. So I would really recommend YouTubing how to do these things, like how do I do a dry powder inhaler? How do I do a meter dose inhaler? How do I do these RespiClicks? Because those are kind of funky devices. Moving on to these are short-acting muscarinic antagonists and long-acting muscarinic antagonists, right? So aclidinium is a long-acting, that Tidorza, this is for COPD. Ipratropium is that short-acting anti-muscarinic antagonist, right? It's also available as an inhaler as Atrovent. Tiotropium long, omeclidinium long, and glycopyrrolate is an old agent, but this is typically as a IV, but they've also made an inhaler out of it. So really the only short-acting on this list is this ipratropium. These are the SABAs, short-acting beta agonists. For the most part, it's albuterol. Medi-Cal, if you have a patient on Medi-Cal, Xopenex is their preferred, levobuterol. When this agent came out, they took one. Every drug molecule has a right and left side, right? A dextra and a sinister isomer. So they took what they thought was the isomer levobuterol, which had most of the efficacy with none of the side effects, and the drug manufacturer said, oh, if you do a levobuterol, it doesn't have a lot of the tachycardia that albuterol has, but that's really not the case. So for all intents and purposes, these are really the same thing. Here's a list of long-acting beta agonists. So we have R-formoterol, formoterol, indacaterol, olodaterol, and salmeterol. Again, good for COPD. Don't use it alone in asthma. These are long-acting and should be used, kind of not on an as-needed basis, but on a scheduled basis. They do make a combination one, and they do make combinations of long-acting beta agonists with long-acting muscarinic antagonists. So that's the list. These are the combinations of steroids plus long-acting beta agonists. These are pretty popular, especially for COPD patients and also asthma patients who aren't controlled. These are the leukotriene modifiers, montelukast being the most popular. This 4 milligram packet can be used as young as, I think it's, 1 year old, 1 to 6 years old. So a 1-year-old can use a granule packet and they can just kind of drink it down. And that helps with some of their symptoms. And just kind of keep in mind the angiitis, vasculitis with angiitis or Churg-Strauss syndrome, and also suicidal ideation. This is the monoclonal antibody, or the IgE antagonist, omalizumab, and that's the information there. These I didn't go over, but these are newer agents. These are interleukin-5 antagonists. So interleukin is a component of the inflammatory system, right? So there's tumor necrosis factor, and there's several interleukins, 1, 6, this one being 5. And so these agents probably not covered by insurance, but again, if a patient's taken everything they've done, this can be helpful, especially if they present with severe eosinophilia. And then lastly, this is a dosing table. So if the chart suggests you start with a medium dose steroid, you can look at the age group here, say like adult, and the insurance says, oh, we only cover fluticasone. So then I would look here and I would say, okay, fluticasone on the HFA, the meter dose inhaler, I'm going to give anywhere from 264 to 440 micrograms per day. Okay, COPD exacerbations. So where this differs in asthma really is that we rely less on the albuterol because it doesn't seem to do as much. And we rely more on the antimuscarinic medications. Okay, so now moving on to drugs for allergic rhinitis, cough, and cold. Allergic rhinitis, I think we're all familiar with those. There is seasonal and perennial. Seasonal being, just in a flu, like in a certain season, such as the fall or in spring. Perennial being kind of all year round. And these are triggered by airborne allergens that then bind and recruit immunoglobulin E onto the mast cell, and that's what triggers the inflammatory and immune response. And with that, you have a high release of histamine, you have a release of leukotrienes, and a release of prostaglandins. One of the more common or most effective, really, treatments for these types of allergies is the inhaled intranasal glucocorticoid. So fluticasone, which goes by the brand name Flonase. These are now available over the counter because they're safe. There's also Nasonex, which is mometasone. So you can see these over the counter. They are just steroids. You do just kind of intranasally, sniff them. Some of the adverse effects are drying, can cause nosebleeds, and rarely headache. So these agents are really the most effective. Now, if you need to combo it, or you don't feel comfortable sticking stuff up your nose, you can recommend the oral antihistamines. Again, I would stick to the second generation ones because they don't cause as much side effects. There are also intranasal antihistamines, and this includes azolastine and olopatadine. And this is if you have allergic rhinitis, runny nose. And part of this effect is due to not only just the histamine blockade, but also its anticholinergic properties to help cause dryness of the nose. Again, cromolyn is also available, very, very safe, not very effective, and takes a very long time for it to work. Sympathomimetics, these are like pseudoephedrine, phenylephrine, oxymetazoline. So you may have seen these agents. Anytime someone complains of congestion, oh, hey doc, I'm congested. These are the agents that are typically you would prescribe for. Couple of things. So they're alpha-1 agonists. So once they stick on there, they'll sit and cause vasoconstriction, usually of the nasal capillaries, and that kind of helps improve the congestion up in the sinus tract. But they are very notorious for tachyphylaxis. So you use them once, they feel great. The effect wears off. You use it again, and it doesn't seem like it's doing as much of a job. So then you feel like, okay, I got to use more. And then you find yourself in this kind of cycle, having to use more and more and more and more. And it can be kind of dangerous, especially for elderly folks or patients that have glaucoma. All right? And then you can also get some addiction. So I think this is labeled on the boxes, but it's typically only recommended for a 3-day use. Certainly try not to go over 3 days in its usage. This chart says 5, I say 3. Topical agents work more quickly. The oral agents will last longer. Obviously, oral agents will have more systemic effects, so that's kind of something you'd have to keep in mind. Rebound congestion is common with the topical agents, but rare with oral agents. Here's kind of a list of the agents: phenylephrine, ephedrine, pseudoephedrine. Yeah. All right. So drugs for cough, what we term antitussives. There are some opioid types, so codeine is probably the most common. You might have seen this with promethazine with codeine is probably the go-to one. They do make one with hydrocodone, which used to be more readily available, but now that it's a Schedule II DEA drug, you don't see it often, if at all. But it used to be combined with antihistamines, so you would have Hycodan, Hydromet, and then hydrocodone alone as this product called Tusionex. Non-opioid antitussives, these are available over the counter. Dextromethorphan being the most common, Robitussin DM, dextromethorphan. Then you can also use diphenhydramine, Benadryl, because of its anticholinergic property. It may have some effect with antitussives. Benzonatate is Tessalon pearls. These are prescription only. They have a funky mechanism, but these can help reduce the cough mechanism. Then you have agents called expectorants. I honestly don't really know if these are effective or not. Guaifenesin being pretty much the only agent. And it's available over the counter as Mucinex. This is for those people who have kind of a productive cough. And so if you have a cough that's, with mucus or has postnasal drip and they're coughing and you want them to be able to cough to get the stuff out, these expectorants help kind of thin the mucus, right? And they help kind of increase the respiratory tract secretions. So that the person coughs is more productive. They can kind of cough that stuff out, and then hopefully they stop coughing. And the dosages range wildly, but anywhere from 6 to 1,200 milligrams twice a day. These are not really over the counter. These are more from the hospital standpoint or a clinic standpoint. You can use hypertonic saline. That will break it up. It's very highly irritating. So I don't think this is kind of a treatment course. This is more for diagnostics when you're trying to do a deep sputum for, like, let's say, tuberculosis. Acetylcysteine can also be used. Again, it's very terrible. It stinks like sulfur, and so most people wouldn't do that either. Just remember the common cold, especially as we near the winter seasons, is typically rhinovirus, which goes away on its own. It's not usually bacterial in nature, which means that we should not prescribe antibiotics such that we don't induce bacterial resistance. And usually these are self-limiting, so just kind of tell patients, give them these symptomatic treatments that we just discussed, tell them to hunker down. Hopefully it'll get better in several days. These are all the things that are available for you over the counter. Just kind of reminders, nasal decongestants. Think of glaucoma, think of the elderly, think of abuse, think of hypertension. These are the things that you probably don't want to prescribe nasal decongestants to. Antitussives, dextromethorphan is relatively safe medication in its prescribed dosages. Acetaminophen or ibuprofen for aches and pains. Zyrtec or Claritin if they need it for kind of allergic rhinitis symptoms. And I don't know why this slide has caffeine, but if you really needed to stay awake, you could drink caffeine if need be. Now, if you get pediatric recommendations and you need to prescribe, most of those prior medications that I described can be given to pediatrics, so you can certainly prescribe acetaminophen, ibuprofen. You can prescribe Zyrtec or Claritin for the young. You probably want to stay away from dextromethorphan, as that can be dangerous for children, and also the nasal decongestants. In those instances, I would recommend consulting a pediatrician, or if you're going to be a nurse practitioner in a pediatric setting, then that's something that you could be cognizant about. And that was it. Again, if there's any questions, please feel free to reach out for this subject or any of the other subjects. And please email me at my main account, josen1@mac.com. Thank you for your time. Appreciate it.